Good afternoon, everyone, and thank you for joining this afternoon. We are excited to be sharing this work focused on the Agency for Healthcare Research and Quality's patient safety indicators. During this listening session, we'll be sharing preliminary results of a gap analysis to inform future PSI work, which could be either refinement of existing PSIs or development of new PSIs. Between May and the end of June, we are accepting public comment on this work, and we really look forward to hearing from you both today and throughout May and June. So before we get into some brief introductions and some background, I'll share the agenda here. We'll begin with some housekeeping before diving into the background and the preliminary findings from the work. And then we will hear from Dr. Annalise Schleyer from University of Washington Medicine for her thoughts on this work from the provider perspective. And finally, we will have some time for discussion, at which point we'll highlight some questions and considerations from the audience that you can submit through the Q&A function. So on to the welcome. I am Wendy Prince. I'm with the MITRE Corporation, and I'm joined today by my colleague, Dr. Alan Levins. Both of us have been involved in this work and are happy to join today. From the AHRQ side, we're joined by Judy George, Karen Chavez, and Whitney Schott. And we'll go on to some quick housekeeping before we kick off with the background information. We, most importantly, are definitely looking to hear from the public. This work is at its preliminary stage, so very early on, and we really want to make sure that it's informed by all of you on the phone today and any of your colleagues who may also want to chime in over the coming months. So please share your input or questions through the Q&A function throughout the session, and we'll be pulling them for the discussion portion of the webinar. If you have questions or comments that are specifically related to the current PSIs, we would encourage you to email AHRQ directly at qisupport@ahrq.org with those questions. Today, we will really be looking sort of to the future, so considering high-level questions and considerations on where do we go from here with the PSI program, and where do we go for future development or refinement of PSIs based on what we know today and what we are seeing as new areas for measurement in preventable harms. If you have any technical support issues, Tom Schofield on the MITRE team is available and prepared to help you if you'd like to contact him or email him. So his information is there. We can also put that in the chat for you. As I already mentioned, this is not going to be your only opportunity to share your thoughts. We're open to your input from now through June 27th, and we really look forward to hearing from you. We're also recording today's discussion so that the recording and the slides can be made available to you following the webinar for reference. Our plan is to take this input and incorporate it into some recommendations to update the patient safety indicators. So as we shared earlier, we'll be reviewing the recent gap analysis to inform future PSI measure development, highlighting gap areas that could be addressed through refinement of existing PSIs or even creating new PSIs. We're looking forward to your input along the way. So please feel free to not hold your questions until the end. As we go through the content, we'd really love for you to submit your questions and considerations along the way via the Q&A function, and particularly during the discussion portion at the end of the session. We've noted several key areas for public input that you can see on this slide, and we'll have our team in the background looking through those, identifying opportunities to maybe think about some common themes that we could have Dr. Schleyer, Dr. Romano, or others react to. So now I'm going to hand it off to our colleague, Judy George at AHRQ, to walk through some of the background and context for why this work is underway.
Thank you, Wendy, and a very warm welcome to all. Emily, Kristen, would you mind advancing the slide? Great. It is my very great pleasure to welcome you and to start off today with a quick introduction of what we are hoping to accomplish today, and just very pleased to have a large turnout. My name is Judy George, and my role is the lead of the AHRQ Quality Indicators program that is at the Agency for Healthcare Research and Quality, which includes several groups of indicators used for quality improvement. The patient safety indicators are one of the most prominent of those, which we develop and maintain. I also wish to acknowledge our colleagues who are on the line from the Center of Quality Improvement and Patient Safety: Whitney Schott, Dave Calfee, Karen Chavez, Erin Grace, Jade Purdue-Pulley, and Craig Umscheid. I'd also wish to thank our speakers today, Drs. Patrick Romano and Annalise Schleyer, who will be speaking shortly, as Wendy mentioned. And I particularly want to acknowledge and thank Peter Pronovost and Sue Sheridan, who have been part of planning today's webinar, and unfortunately were unable to participate today. So let me start off with the motivation for AHRQ to hold today's webinar and what AHRQ hopes to achieve through today's session. This webinar, as Wendy mentioned, is forward-looking, a forward-looking focus considering what types of patient safety measures may be required in the next 5 to 10 plus years. AHRQ sought an independent evaluation to consider these broader gaps and opportunities to adapt the PSIs to current and evolving patient safety measurement needs. AHRQ has been thinking about this for several years, and as NQF, the National Quality Forum, initiated an update to the 2011 Serious Reportable Event List last year, AHRQ secured funding to begin this work, and that independent evaluation is being completed by MITRE. MITRE's work that will be presented today and summarized in the gap analysis document is the first stage of information gathering. And today's webinar aims to capture your input, the public input, and from important perspectives that we believe are included on this call, and hopefully looking forward to hearing from those, from patients, states, providers, health systems, researchers, insurance, health plans, and others. And since this will be a forward-looking webinar, suggestions or questions about the existing PSIs are really out of scope. And those questions or any suggestions are always welcome to our technical support email, and we'll add that into the chat so you have that readily available. So as I transition over to handing the mic over to Patrick, Dr. Romano, let me start with a quick introduction of the PSIs, which many of you are probably aware of. The AHRQ Patient Safety Indicators, or PSIs, which are part of this Quality Indicators program, were first developed about 20 years ago to identify preventable harm that patients experience as a result of exposure to the healthcare system and are likely amenable to prevention. AHRQ's annual software update process includes updates to existing PSIs, which include both minor and significant updates. And these PSIs, as folks know, are commonly leveraged by states and hospital associations to assess potential quality improvement opportunities. So for that reason, AHRQ recognizes the importance that PSI evolve alongside the changing landscape of patient safety. So it's with great pleasure that I introduce my esteemed colleague, Dr. Patrick Romano from the University of California, Davis School of Medicine, who is a principal scientific and clinical advisor to our team with developing and maintaining the AHRQ PSIs, who will share more about the history and development of the PSI program and indicators, as well as some of the more recent work underway. Patrick, I turn it over to you.
Thank you very much, Judy. So I'll begin just by reminding the audience here that the AHRQ Quality Indicators program was really born out of the mission of AHRQ to enhance the quality, appropriateness, and effectiveness of health services and access to such services, really building a broad base of scientific research and promoting improvement practices. Next slide. So the origin of the AHRQ Quality Indicators Program really came out of the Healthcare Cost and Utilization Project, or HCUP, which started back in 1988. And as most of you know, HCUP is a family of healthcare databases and related software and products developed through a federal state industry partnership sponsored by AHRQ. It includes the largest collection of all patient and counter-level hospital care information in the US, including all the different databases shown here. On the next slide, the HCUP state partners that contribute data to HCUP really asked AHRQ, help us make better use of our data. Help us understand how we can use our data. So the basic approach at the very beginning of the QI program over 20 years ago was to identify indicators of quality, including patient safety, that could be used to highlight potential concerns, identify areas needing further study and research, track changes over time, and facilitate transparency and informed decision-making and policy, driving improvement across the healthcare industry. The original design parameters that the UCSF Stanford team was given back between 2000 and 2003 was to use hospital discharge data from HCUP, the program, and the HCUP partners without linking data sets, without using patient identifiable data, to use available data elements to maximize generalizability across the entire country, and to establish national benchmarking using risk adjustment as needed to try to create a level playing field for comparisons. Next slide. So the original vision that was described back in 2005 for the QI program, including the PSI component, was to develop, maintain, and evolve measures over time, adding new measures and modules as needed. So this session that we're having today and the gap analysis that MITRE has done is very much part of this ongoing vision that was established 20 years ago. The vision also included strengthening administrative data at the federal, state, and local levels, and adding more states, more data sources, creating a set of tools to facilitate use of the indicators, including free downloadable software, dashboards, reporting templates, a full set of documentation, and then bringing change through strategies and partnerships. Again, this listening session is part of that 20-year strategy, including HCUP partners, hospital and industry associations, state and local governments, employers, purchaser coalitions, our federal partners, researchers, advocates, other users, all as part of this effort to continue evolving the quality indicators, and then to monitor and evaluate the impact over time. Next slide. So this graphically represents 20 years later how this vision is operationalized. So again, our mission in the QI program and for the PSIs in particular is to produce scientifically sound measures and software for healthcare users to identify potential quality and safety improvement opportunities. The program really depends on user engagement and being responsive to users, conducting evidence scans, environmental scans, assessing the clinical validity of the measures, using scientific methods, and then iteratively improving the measures, including the specifications, the software, the instructions, and this incremental process of adding and removing measures. Next slide. So this is the roadmap that we currently follow. We iteratively go through the process of identifying candidate measures, their target users and use cases, gathering feedback from audiences like this one, identifying databases, assessing those databases, conducting analytics, feasibility, validity, reliability testing, and then developing artifacts, public specifications, software value sets, methods documents, benchmarking data to support the ongoing use of the measures. Next slide. And this demonstrates how the program currently operationalizes this vision. Again, it's a complex slide, but you'll notice all of the inputs that go in, the technical assistance process, which elicits user suggestions. Those user suggestions lead to enhancement, coding, and measure updates, refinements, risk adjustment, again, an iterative process of development. Next slide. So these two slides just briefly present the history of the specific patient safety indicators. So we began actually with about 29 indicators because several of the indicators denoted with asterisks had area level versions as well as the hospital level versions that you currently see. As you can see looking down this list, the PSIs have changed over the years. Several have been modified or updated. Their names in some cases have been made more precise. In some cases, they've been expanded. For example, postoperative hip fracture is now in-hospital fall-associated fracture. Some of these indicators have been retired or will be retired shortly. Next slide. And this is the second set of those patient safety indicators, again, highlighting that several of them have evolved over time or have been retired. Again, we have an ongoing log, which is referenced at the bottom, where you can see all the details about every change that's been made since 2002 in the specifications for the program. Next slide. So the next two slides present some of the key milestones in the history of the program over the past 23 years. So 2002, AHRQ released version 1 of the patient safety indicators, or PSIs. And since then, AHRQ has released approximately one version each year. We're now numbering the versions by calendar year. So version 2025 is currently in testing. 2003, AHRQ released the first software that could be downloaded and implemented by any user. At first, it was in SAS and SPSS. It included risk adjustment models with parameter estimates and the ability to estimate confidence intervals at the hospital or area level. And the same year, PSIs were added to AHRQ's National Healthcare Quality Report and Disparities Report. In 2006, AHRQ first released a Windows version of the QI software and began phasing out the SPSS version. And it has continued to release SAS and Windows versions each year since then. In 2008, AHRQ launched the National PSI Validation Pilot Project to solicit volunteers to gather evidence from detailed chart review, focusing on the clinical performance of the PSIs. And these validation efforts led to a whole series of publications in the peer-reviewed literature. Some of you may have seen these, but they focused largely on what we call the positive predictive value of the indicators. In other words, when PSI 12 flags an event like a postoperative pulmonary embolus or deep vein thrombosis, how likely is it that the patient actually experienced that event after surgery? So this is what we mean by the PPV, the accuracy once the patient is flagged as having the event. AHRQ also launched a tool to facilitate HCUP partners' efforts to publicly report on the AHRQ quality indicators. And that tool was used by many state partners for many years to facilitate public reporting. Around 2009, 2010, AHRQ incorporated smoothing or shrinkage into the design of the indicators to improve the reliability and the validity of the individual estimates of hospital performance. And AHRQ also incorporated POA information into that PSI process. Next slide. Over the next several years, AHRQ continued to expand the use of POA information until now. Of course, the software depends on that information across all indicators. In 2012, AHRQ released the first toolkit for hospitals to provide specific guidance about how to use the PSIs to drive quality improvement. In 2015, the culmination of a 2-year effort to transition all of the PSIs and all the quality indicators from ICD 9-CM to 10-CM and PCS. And this also incorporated major updates to the specifications, reflecting the results of all the validation studies, so that we could optimize the positive predictive value, the performance, if you will, the criterion validity of all the PSIs. In 2016, AHRQ released the first harm and frequency weighted patient safety and adverse event composite. This is, of course, labeled now as PSI 90, and it's been widely adopted across the healthcare industry as a composite measure, now including 10 of the specific PSI events. 3 years later, 2019, AHRQ continued to incrementally improve its methods for risk adjustment, adopting modern machine learning methods for feature selection in the PSI models, more robust methods for assessing the models as they're being developed. The same year, all area level PSIs were retired. The hospital level PSIs were retained. And finally, just in the last year, as part of our current improvement contract with Mathematica, our team at UC Davis implemented interaction selection methods to selected risk adjustment models to further improve the models. And also AHRQ has released maternal health indicators now in a beta module. Next slide. So this is just a graphic representation of the incremental process of improving the risk adjustment process. Again, we've worked very closely between my team, Dr. Monica Ray, the analytic lead, and Dr. Sheng Wang and Alex Bohl at Mathematica on this incremental process of feature engineering, model fitting, model diagnostics, and improvement to get better prediction and level the playing field across hospitals. Next slide. And this previews what's happening for 2025. So AHRQ has decided to expand the quality indicators with a new module for diagnostic safety quality indicators. And these measures are currently underdeveloped. They will focus on the timing of the diagnostic process, diagnostic delay, particularly related to cancer diagnosis. And we look forward to sharing more details about those measures. AHRQ has published a request for information, has received a lot of feedback from the user community through the Federal Register, as well as through an external work group. Next slide. So as I turn things back to Judy, I just remind everyone that the RQI program really offers a full set of resources, including software, documents. There are a lot of published papers that have evaluated and used the AHRQ PSIs. We welcome technical assistance queries, comments, and suggestions. I personally, and some of us on this call, respond to those every day. And this provides some information about how to provide that input and where to go for more information about the software and documentation. So we look forward to hearing about the gaps that have been identified and the opportunities for the RQI program to fill some of those gaps. So thank you very much, and I'll turn things back to Judy.
Thank you, Patrick, for that excellent overview of what the patient safety indicators are, the process used to develop them, some of the key milestones, and where we're looking to go as of right now. As we transition to the next portion, I think what I would like to share are just a few comments here that our measures have historically focused on acute care, but as we know, harms to patients occur across the healthcare system, including ambulatory, long-term, and community-based settings. So it's especially important for AHRQ to focus on addressing harm where patients are experiencing them. And with great consideration of patients with chronic conditions, because these individuals often require ongoing medical care for frequent interactions with the healthcare system and complex treatment regimens. And these frequent interactions with the healthcare system don't always occur in inpatient settings where current measures are largely focused. So the work that we will be talking about today did not happen in a vacuum. And our webinar is where this star on the second part of this process flow diagram. It didn't happen in a vacuum. AHRQ has been collaborating with other measurement efforts underway. For example, the National Quality Forum, as I mentioned earlier, launched the Focus on Harm initiative to update the SRE list. Working with our CMS colleagues, who have highlighted that safety is a goal within their Meaningful Measure 2.0 framework, an initiative to address measurement gaps and reduce measurement burden was an underpinning framework that the MITRE team used. Similarly, healthcare-associated infections are listed as part of the gap analysis. Now, these are part of gaps identified as a whole, after which AHRQ would consider with its sister agencies, CDC, CMS, and others, to determine which of those gaps would be most appropriate and feasible for AHRQ to pursue exploratory measure development. So within that context, and looking to build on recent and ongoing efforts, AHRQ seeks to update the patient safety indicators to better reflect preventable harm across the healthcare landscape as it is today and what we expect it to be in the coming years. So in a moment, I'm handing this, the rest of the webinar back to the MITRE team. And before I do that, I want to point out and reinforce what have been stated, that this is preliminary work. And the first stage does highlight these gaps that they will be walking through, including the methods that are used. Wendy mentioned that the new work will focus on refinement of existing PSIs and creation of new PSIs. I also want to reinforce that this effort will also consider which PSIs are ready for retirement. The second stage of this work begins today. And so that's the part of inviting your input, especially from patients, providers, states, and others that we have mentioned. MITRE will summarize the comments received from the public, and it would be considered along with the gap analysis that they've conducted, and hold a multi-stakeholder coalition meeting that will be held this summer. And that coalition will be represented by patients, providers, states, researchers, and health plans. Considering all three of those input sources, MITRE will provide AHRQ recommendations for gaps and opportunities to update the AHRQ PSIs. AHRQ will then use those recommendations to determine changes needed for the PSI program alongside our sister agencies and align with HHS priorities. So in holding this webinar and sharing with you this early document in progress, AHRQ is taking a risk here. We are being bold and doing so in hopes of hearing from you all sooner to assure that what we are doing in our plans are in lockstep in considering what is important and those that are less important based on your perspectives. And so in what is important and less important in consideration of future patient safety measurement needs, to be specific. So with that, Wendy, let me hand it over to you.
Great, thank you. So I'm going to spend a little bit of time walking through the methods that we used at a pretty high level, and then we'll start getting into the meat of the conversation around the domains and subdomains and where we might go from here. So This is a pretty high-level overview of the steps that the team took to begin thinking about the gap areas and measurement opportunities. And I'll note, while they appear sequentially, some of the work was actually taking place in parallel just to sort of maximize our efficiency along the way. We began with a synthesis of preventable harm domains from existing safety frameworks, as well as an environmental scan of preventable patient safety harms. We then developed this preliminary preventable harm measurement framework with domains and subdomains to guide further efforts, and use that framework then to consider where there may be opportunities for gaps within those domains and subdomains without getting, I would say, too deep into actual measurement opportunities. So we'll dive a little bit further into each of these steps on the next slides. So when we started with a review of existing safety frameworks to look at common domains, obviously there were many things to look back to, including, going back to the research from To Err Is Human and looking at how they thought about different aspects of safety. We leveraged AHRQ's common format for event reporting, for example. Judy has already mentioned the NQF work on serious reportable events. So we took a look at the work that they had done in the past and how they sort of categorize different areas of harms. And through that effort, we essentially landed on 6 common domains, and you'll see those here on the screen. Diagnostic safety events, we've spoken to already a little bit. Adverse drug or blood product events, healthcare-associated infections, healthcare-associated conditions, patient environment harms, and mortality. And we'll get into our working definitions of each of those in a few slides when I hand it over to my colleague, Alan. So you can see some of these are not new. They've been around for a long time. And so there may be opportunities within these domains to think about new ways of looking at PSIs, as well as where there are maybe areas where there is nothing currently, what could be sort of done more de novo. So on the next slide, after we identified those common domains, we conducted an environmental scan of the patient safety literature to explore the need for measurement of harm across different settings, special populations, and priority areas. And as others have mentioned previously, really needing to expand beyond the purview of the hospital. We know that there are harms that take place in the ambulatory setting, in the home setting, and so really wanting to make sure that we're considering that full spectrum of care and not focusing solely on one place where people, by and large, don't spend the majority of their time. Certainly, that's where a lot of harms do occur, but we really wanted to make sure we were taking a more holistic view of the patient's journey through the healthcare system. So the settings that we focused on included ambulatory care, home health, hospice, hospital inpatient still, outpatient psychiatric facilities, rehab facilities, skilled nursing facilities. We also wanted to take a specific look at special populations, so not just the older adults, but really looking at what are the major harms that happen to children or to young adults or to older adults or maternal populations and behavioral populations. And then, another interesting aspect that we wanted to touch on, or there are a number of emerging topics around harms that we wanted to sort of poke around a little bit in and see what we could find. And so those included areas such as health information technology, or EHR use, artificial intelligence, care transitions. We've talked about that a little bit. Telehealth is a new modality of care where there has not been a lot in the literature about what some of the safety issues might be there. Radiology and failure to rescue. So we try to have this more comprehensive look, not just setting by setting, but really thinking across the board how we might elucidate harms that are reported in the literature, but also that might be more on the emerging end of things. So you can see on this slide some of the sources that we used. I won't go through the details here, but we looked at the Making Healthcare Safer reports. We did some searches on PubMed. We looked at some gray literature from some prominent patient safety and healthcare related organizations. And we looked at several states who have state safety reporting programs, and reviewed all of that information to come up with what we are presenting here today. So the next slide. So, the environmental scan helped us inform updates to the domains and helped us create some subdomains to provide some additional structure within each domain for this framework. And to the extent practical, we also wanted to consider how the domains and subdomains reflect different stages of care, including prevention, diagnosis, treatment, outcomes. Again, it's, because a lot of the focus has been on the inpatient care, we wanted to make sure that we paid due attention to what's happening in the pre-acute settings, what's happening in the preventive space when people are being diagnosed, receiving treatment, whether it's inpatient or outpatient, and then outcomes. So it was important to us to make sure to keep that front and center as we went through this process. You'll note that these are not meant to be sort of a mapping one-to-one to the stages of care. The stages of care are really more of a kind of a guiding principle, because certainly any of the harms that take place within these domains could take place at multiple places along the stages of care. So again, wanting to just really make sure that we're keeping an open lens and not becoming too myopic in our thinking here. As we move on, with the subdomains on this side, you can see we've started to identify subdomains within each domain. And again, these were informed by the environmental scan. And this is where we're really hoping that the public and all of you on the line can offer some additional insights to advance this work. Under diagnostic events, we included subdomains for misdiagnoses and wrong diagnoses. Under adverse drug or blood product error, we've included adverse drug events and adverse blood product events, which could include things related to preventable errors in the administration of medications or blood products, providing the wrong drug or blood product, or inadvertently administering a wrong dosage. So a number of things that we could think about in that space. Under HAIs, we've included subdomains for product and device-related HAIs, surgery-related HAIs, and a subdomain for other HAIs which might not fit in those specific ones aforementioned. For HACs, we've included patient care events, procedural events, surgical events, and anesthesia events. And again, we'll dive a little more deeply into those areas in a few slides. For patient environment harm, we've included device failures and patient protection events, which are harms that could be caused by errors or deficiencies in the resources within the healthcare environment. They could include things such as injuries caused by malfunctioning devices or patient elopement, things that you might start to think about in other settings that might be important. And finally, under mortality, which we recognize as a cross-cutting domain in and of itself, we've included rescue failures and unexpected deaths. So, these would be more patient deaths in a healthcare setting that were unexpected based on, inadequate provision of appropriate healthcare interventions, or their occurrence in groups with lower risk of mortality. So following this development of these domains and subdomains, and again, I will I will reemphasize, Judy and I probably will reuse the word preliminary many times throughout this session, but these are a starting point where we're really looking for feedback from you. But at this stage, what we did was we took to a mapping exercise, looking at the subdomains and identifying which ones had current PSIs and which ones did not. So you can see a number of the PSIs fall under HAIs and HACs. Those two areas are probably pretty longstanding in the safety space, so that's not surprising. Also, PSIs in mortality, but not currently in the diagnostic safety event and drug or blood product domains. Certainly, we've heard already that there is work going on in the diagnostic safety space. So it's not completely void, but there is nothing there currently yet. And again, we'll dive into these in a few slides. So we then tried to wrap everything up into a larger framework. So here you see everything that's sort of pulling it all together. At the top, you'll see, again, our guiding sort of stages of care to make sure we're thinking about the full complement of services that patients might receive and where harms may occur. And then you have the 6 domains, and then we've separated out to show where there are PSIs. Those are reflected in the green. So under each domain, the subdomains where we have PSIs already, and then the boxes in the yellow below show where there are gaps and there are not PSIs reflected. And that, I think, an important caveat here is just because there are things in the green does not necessarily mean that there isn't more work to do or that there aren't new and emerging PSIs that fit within each of these. So our intention is not to say, okay, we can check those off and move on and just focus on the gaps in the yellow, but really think about discern what's in those, and based on the literature and based on the feedback that we receive from you, are there opportunities even within the domains that already have PSIs to think about new ones, how to modify either to extend settings or to different populations, and then obviously pay attention to the area in yellow because there is nothing there. And so we would really appreciate your feedback as to where things really resonate, what might be most important to you, what might not be as important to you. So as we move forward, definitely I see some Q&As starting to come in, so that's great. So keep them coming. So at this point, we're going to move on to a little bit more of a granular conversation about the domains and subdomains. And I will, again, reiterate, this is early stages, opportunities to refine, help us rethink some areas, and advance our thinking here. So I'm going to pass it over now to my colleague, Dr. Alan Levins, to walk through the next set of slides.
Great. Thanks so much, Wendy. And that was a super summary of the work leading up to our development of the domains and subdomains. I'll just initially emphasize a couple of points that Wendy made in terms of the subdomains and domains were intended to focus on specific preventable harms rather than the underlying drivers of harm. So you'll see that reflected in both again, the overarching domains and the more specific subdomains. But things like care transitions certainly came up frequently in the research, and we recognize that there's a need to consider those, but just as that context for the framework and these domains that we landed on. And the second point is that certainly there's going to be some overlap in terms of specific events that could fall into multiple domains. But again, we try to minimize that overlap and also ensure we're covering all the key areas. So with that stated, we'll start here with diagnostic safety events. And again, this has come up a couple times already in the discussion today, but we did land on having 2 subdomains. And basically our working definition for this domain was that it is a failure to establish an accurate or timely explanation of the patient's health problem, or failure to communicate this explanation to the patient. So the first subdomain of misdiagnoses could be such things as a clinician not initially recognizing a condition based on relevant signs or symptoms. It could be something like a lost biological specimen that could inform the diagnosis, or problems missed on an imaging test that, again, lead to a misdiagnosis. So a specific example here would be an individual presents to the clinic with symptoms of depression, but because they did not have a screening test done, that opportunity to diagnose that depression is missed, and that could lead to obviously very negative repercussions. A wrong diagnosis is where an individual receives the diagnosis that doesn't accurately represent their health status. So we have an example here of a misdiagnosis of sepsis, which could sometimes be confused with other conditions related to cardio or respiratory conditions, and again, could lead to serious harm if not addressed quickly. And as you can see, we have no current PSIs in this domain, so certainly a potential opportunity area, again, recognizing that there are some challenges in things like consistent definitions and criteria for what constitutes a missed or wrong diagnosis. Next slide, please. Adverse drug or blood product events were grouped together because there's obviously many similarities between these two. So you could have an individual with the wrong drug or blood product given entirely. It could be the wrong dose or amount of that drug or blood product, or giving the drug or blood product to a patient with a known contraindication to that substance. And again, we have no current PSIs in this domain, so maybe a prime opportunity for development, but again, recognizing that there are challenges and there may have been good reasons why this has been a challenging area to have a PSI, so be interested in input on this domain. Next slide, please. So for healthcare-associated infections, our working definition was pretty simple. Infections that in patients that arise during the course of healthcare delivery. We did divide this into the three subdomains you see here. So product or device-related healthcare-associated infections could be things like catheter-associated infections. We have surgical related infections, which would be something like a surgical site infection, and then product and device-related infections. HI is not related to product or devices or surgery, which could be things related to improper hygiene, so lack of proper hand washing, or things of that nature. So again, we have that latter area where we have no PSIs, but we do have a couple of existing current PSIs, one for the product device related subdomain and one for surgery related. Next slide, please. So healthcare-associated conditions is a pretty broad category, and our working definition here was events that are not addressed essentially in other domains and that occur as a result of specific actions or inactions taken during the provision of healthcare services. So we did divide this up into 4 subdomains, 3 of which you see there's a number of existing current PSIs. As Wendy mentioned, that doesn't necessarily mean that we may not need additional PSIs, or that some of these may need to be modified at some point. But this is one area where we did want to particularly note that there is quite a few existing PSIs. So anesthesia events I'll call out because this is one that we actually discussed whether or not it would be justifiable as an additional subdomain, but we did see quite a bit of research and previous discussion around whether this is an area that may be suitable for PSIs. And I think Patrick pointed out that there was a prior PSI in this area which was retired, so may be useful to revisit that in terms of some of the challenges that exist. So I won't go through each of these since there's so many, but certainly, again, this is an area where think it'd be worth a look for folks and be interested in feedback on the existing ones as well as potential gaps. Next slide, please. So patient environment harm is essentially a place where we're trying to capture harm events that could be caused by failures or deficiencies in the healthcare environment. And we divided this into two subdomains. Device failures would be things like a malfunctioning device that leads to a burn or a shock of a patient. And then the patient protection events subdomain is non-device related issues, but still more environment related. And this could be something, an example here we listed where a patient is discharged from the hospital, but they don't receive the necessary equipment that they need after discharge. And obviously that could lead to negative repercussions. And again, in this domain, we see that there are no current PSIs, so could be a prime opportunity area if folks have good suggestions for this one. Next slide, please. So our last domain is mortality, and this covers patient deaths in a healthcare setting that are unexpected. And our two subdomains include rescue failures and specifically unexpected deaths. So rescue failures would be issues where a patient has considered to be a serious but treatable condition, but there's not sufficient attention or intervention taken to address the healthcare issue. And you can see there's one currently existing PSI to address that. And then unexpected deaths would be a broader subdomain where we're looking at specific categories of patients who would not be expected to experience mortality. And the current PSI death rate in low mortality diagnosis related groups is what we have currently. An example here would be clearly low risk maternity care or a full term newborn where there aren't other issues where you would expect this to lead to mortality, and obviously a very serious and challenging issue to address. So I think at this point, I'm going to thank folks for the opportunity to share this overview of the domains, and I'm sure we'll have some more discussion about these later, but I'll now hand things off to Dr. Annalise Schleyer to discuss the provider perspective.
Great. Well, thank you so much. And I really appreciate the opportunity to be here today. I think this is a really important opportunity and really just want to share my thanks to everyone for having an opportunity for all of you to listen and get people's input. So thank you for that. I'm Annalise Schleyer. I am a practicing hospitalist for the last 23 years. I am currently Chief Medical Officer of UW Medicine in Seattle, Washington. And in my administrative roles over the years, I have been partnering with leaders across our system to really focus on quality improvement and patient safety. As those of you who I know here, patient safety indicators have really been at the cornerstone of some of the work that we have done across our health system to identify areas for improvement and to measure the impact of our improvement initiatives. We have used existing PSIs to really engage all the members of our care team, our physicians and APPs, our nurses, our pharmacists, our QI teams, as well as all the learners across our academic health system, in really thinking about patient safety through the lens of a patient. And I still do quite a bit of patient care, and I think it's always my North Star to say from a patient's perspective, they expect to come to a healthcare system to heal from whatever it is they're presenting with, and they don't expect to receive something unexpected, right? So I think they really keep me safe is really almost the number one principle that I think about when I take care of patients, really as a North Star. I will say some of the things around PSIs that have been so valuable for us is that, again, they have been focused in areas that have been very meaningful to all members of our care team, which has helped us to engage in this work. We all, those of us who take care of patients, say, you know, this is something that does impact our patients, and none of us want to see these happen. So I think really relevant They have been evidence-based, they have been measurable, and they have really helped us to understand our organizational data and performance. And again, they're actionable, right? So really thinking about if we identify areas for improvement and we make changes, how do we ensure that we are seeing improved outcomes? And finally, PSIs have really presented a way for us to benchmark ourselves both nationally, and we're a multi-hospital system, so really to be able to look across our system and say, where are those opportunities and how do we ensure that we're sharing leading practices? So I think PSIs have really been central to so much of the quality and safety work that we have done across our health system. So thinking about this effort today and really the opportunity to give input into these measures, I've seen some of the early Q&A, right? The importance of hearing from those people we're here to serve, right? All members of the clinical care team, our patients and families, certainly our health systems and insurance, right? Really everything across our healthcare system. This is a really important conversation to have. So thank you. I would say that why is it so important to me? I think because as Dr. Romero highlighted, right, there have been PSI was created for a really important reason, but it has evolved over time to reflect the national landscape and to reflect priorities. And I think it continues to do that. And that is really part of this conversation. Certainly in the last few years, we all acknowledge that healthcare and patient safety have changed dramatically. We have increasingly complex systems, increased financial pressures, and also we have also seen a lot more engagement from patients and families in their own health and healthcare. So again, patient voice is really key to some of this work. I also say, all of us, regardless of our role here on this webinar or in a healthcare system, all of us are both involved in this work, but we are also all patients, or we all have family or friends or coworkers who are patients. And so I think this is something that we can all unite on and really think about how important this work is. I really want to so that's sort of my background of why I'm here. Again, really appreciate the opportunity to be here. PSI has been a really important part of our quality safety journey.
Thanks, Annalise, for those thoughtful insights and initial reactions to the work. It's really helpful to hear your provider perspective on this, and we hope that it'll spur others to share their insights. We're now going to shift over to the discussion portion of this listening session, during which we would love to hear more from you and from the public on some questions and comments. And as a reminder, please feel free to continue to use the Q&A function. It's been very busy, so some we're able to answer kind of offline, but we're hoping to get to a few of those. On the next slide, we've got just a few, there we go, a few questions that I think you've remarked on maybe a little bit, but would love your reactions to these first three questions of, from the domains and the subdomains, are there areas that you would add, delete, modify? Would you prioritize or deprioritize any of them? And then from your perspective of working directly with patients, do you feel like there are things that we're missing that are really important to them and to what their experiences are like and what they're feeling are the main safety issues that they're experiencing across their spectrum of care?
Wendy, thank you for the question, and I'm happy to offer my thoughts and then look forward to an ongoing conversation. I would say that the domains really resonate with me as I think about patient care across the continuum. I think diagnostic safety is really an area, diagnostic excellence is really an area that has become a bigger focus, right, for our patients and for our national landscape. as I think about the subdomains and a misdiagnosis, clinically, I think of it as a delay in diagnosis, and I would think about it in two different ways. One is area around screening, right? So as you had the prevention to outcomes, what role does screening play? Some of that reflects healthcare system challenges about getting people in, but suicide prevention screening might be an area for consideration. I think also somebody mentioned in the chat about diagnostic imaging. So I do think this focus on diagnostic safety is incredibly important. And it's really the beginning, both Judy highlighted some of the work around chronic disease management, right? It's really identifying those diagnoses up front, so across the continuum. So I think that is really helpful, and really glad to see AHRQ and other organizations focusing on this. I think adverse drug or blood product events, healthcare associated conditions, infections, those are important because we know there are evidence-based areas that we know can prevent some of this work. So, or these events. So I think that is incredibly valuable. I think patient environment harm and mortality makes sense to me as well. I think some of the areas that I think about healthcare through the lens of a patient is really across the continuum. So thank you for highlighting that in your overarching review. And diagnosis, for example, is one area where a lot of that may happen in the ambulatory setting. And so I really appreciate the approach on including ambulatory, but I also think those transitions of care, that's where a lot of those challenges are. And that's sometimes where delay in diagnosis happens, is by the complexities of transitions of care between ambulatory and inpatient settings, or also with longer term care facilities. Another area that you highlighted that I really appreciate is thinking about how we use different modalities. I think this is a very rapidly changing landscape, but certainly AI is something to consider in the next, it's a rapidly changing landscape, but how AI could either support organizations to improve some of these areas, or where are some of the challenges in documentation. Telehealth is another area that you mentioned, Wendy, that I think is really important. One thing that comes to mind as I think about my clinical practice is that communication is so key to patient safety in so many ways. And clearly communication is a little bit harder to measure electronically, but I do think one area as I think about this, for example, in the domain of mortality, is understanding our patients' expressed wishes. So advanced directives or legal next of kin, I think some of those things over time may be something that could reflect communication with patients and families and could potentially be measurable in an electronic way. So those are my thoughts on domains and subdomains. I think gap. The only other thing I would say on domains and subdomains is I really appreciated the detail examples. I think when you think about diagnostic accuracy or wrong diagnoses, I think making sure that we consider diagnoses that have very clear definitions and standard definitions. So there are clear definitions, for example, for COPD or diabetes, which can make that really helpful. I think sepsis may be an area where it's an evolving landscape. In terms of gap areas, I think I've highlighted some of those things around transitions of care. And I would say I have seen alignment with patient experience. I have spent a lot of time with patients asking them about their experiences in the healthcare setting. And certainly these areas resonate with those conversations. And then I guess I would say transitions of care, that's a really challenging area for many patients and families.
Great, thank you for all of that. I would like to see if we could unmute one of our participants, Libby Hoy from Patient Family Centered Care partners who's on the line. And as we've gone into, Annalise, I really appreciate your comments on patient experience. And I'm wondering if we could have Libby react a little bit as well.
Hi, can you guys hear me okay? Oh, getting an echo.
Yes, a little echo.
There we go. I figured it out. Are we good now?
Yes, perfect.
Okay, perfect. Thank you so much for the invitation to comment. This has been so helpful. Dr. Romano's contextual information up front was so helpful to me from the patient family perspective to be able to really engage in that work. And just the fact that you're even inviting patients and family members to a meeting like this. And Dr. Scheller, I probably didn't say your name right, but I loved the way that you're also thinking about how do patients and families, how does good communication contribute to patient safety? And I think I love the directions that this is headed. What I appreciate from I should introduce myself, shouldn't I? So I'm Libby Hoy. I'm the founder and CEO of PFCC Partners. We're an organization that works across the healthcare ecosystem to develop effective and impactful patient-family partnership programs. We also host the PFA network, which is now up to over 1,100 people like myself using our lived experience to participate in partnership activities and co-designed in health systems and in health centers, research, measure development, you name it. So what's great about that, and the reason I share that, is that we have these conversations all the time. You know, where are people feeling unsafe? Where are people experiencing harm? And so it's with that lens that I'm participating in this conversation today. And I appreciate the fact that you're moving beyond the hospital walls into the community, because that's where we really, have to navigate our care systems. And so I realize that it's really hard to nail down effective complex care management or care transitions. But I can tell you from listening and from my own experience that that's where we get dropped, right? That's where things drop off, and the patient safety events start there. Oftentimes, by the time we get into the healthcare system, the factors that are contributing to that patient safety event have already been put in play. And so how do we kind of capture those in the gaps? I think that would be hugely important. I also, addition of diagnostic safety events, I think, is just essential. It's just, there's so much there that people have experienced. And so I think definitely adding that and really putting some bulk under what is misdiagnosis, what delayed diagnosis, whatever you want to call it, and what are those contributing factors. So for instance, we talk a lot in the network about, access to care. And where is the health plan in all of this, right? Because oftentimes diagnosis is delayed, treatment can be delayed based on pre-authorizations, based on, the complexity of navigating your health plan. And so where does that fit in? Because that is a contributing factor for a lot of our patients and our family caregivers. And then secondly, I think, adverse drug or product events, really relevant. Healthcare associated infections and conditions, super relevant. Patient environment harm really intrigues me, because I think there's some more that we could look into in that area. So for instance, to me, the environment includes cultural and disparities care. So how are disparities impacting harm? How are people, receiving services in different communities? And so I wonder if we could, add in there. I also think, to Dr. Schiller's point about communication, how does patient engagement, how does the level to which people are able to engage in their care, how does that affect patient safety? We've seen a lot, again, in our network by definition is highly engaged people, right? So how does that impact? How are they contributing to the safety of their care in ways that other patients may not have the opportunity to do? That's not just about a personality, it's about a system that has space for patient and family engagement, that has it hardwired into their admissions processes, their discharge processes. And so there's a whole lot in that patient environment area that I really love to kind of push the envelope and think about. And then in terms of alignment with patient experience, I do think that these are very relevant to what we hear regularly from our PFA network members. So I think that the alignment is really good, and I would just suggest those, maybe they're reaching for the stars, but what else are we going to do? So let's go and bring patient safety, bring patients and families, bring health plans in, everybody in for patient safety. So I hope that's helpful. Thank you so much for the opportunity to comment.
I need to unmute myself. We've had a couple of questions coming in, and I think it kind of tacks on to what you were saying, Libby, and even at least some of the things that you were talking about. And there's probably not an answer, but sort of as we think about this work moving forward, where do we find a way to think about the harms that are associated with things like failure to partner effectively with a patient or family, or for longer term health, lack of interpreters, lack of low literacy, homelessness that leads to repeated admissions, a lot of these contextual things, hypertension that's maybe undetected, and then that leads to problems later on. We've talked a little bit about, what we're looking at here are the harms, the things that actually happen to the patient, but we know that there are a lot of underlying systematic root causes that contribute to not one but many of these. And so, as you're thinking about, where do we go with PSIs? I wonder if you have any thoughts on that. And Dr. Romano, I might actually ask you to chime in here as well.
Yeah, I'd be happy to offer some thoughts on that. I think that is an incredibly important topic. And I work in a safety net urban hospitals. So this is something I think about often. And it comes back to what Libby highlighted, right? It's communication, and it's understanding. It's culturally competent communication. It's a willingness to listen. A little bit harder to measure on a grand scale, but I do think areas that we know may impact access to care, appropriate communication. There are some things you can measure. Certainly, as you highlighted, interpreter use is one area. I think when you think about digital health, we talk about a digital divide. There are some people who digital health can really improve access for many people, but not everyone has access to that. So I do think there are some measurable areas. I think in some ways, those types of factors, Wendy, fit into risk adjustment, right? There's clinical risk adjustment. People have clinical factors that increase risk, but there are also both structural health system factors. Insurance is one of them that Libby highlighted, interpreter use, et cetera. So I think it's a great thing to think about, and important to reflect that in some of this measurement. I don't know, Dr. Romano, I also just want to highlight, it was really helpful to hear from Dr. Romano, the evolution of PSI. And I think this is a really important time to continue that evolution for all the reasons that Libby and others have highlighted, is that it's a different time, and we have more acknowledgement of what impacts patient safety in some way.
Nothing to add right now.
Okay. I think maybe then, in the interest of time, let's move to the next slide. We have another few questions that we'd like your thoughts on, and others. Again, we've had a lot of engagement through the Q&A, so please continue to feed us your thoughts and your comments. This gets a little bit more maybe the technical side of measures, but in your experience, from the measure specification side of it, is it important for the PSIs to be really specific, to be able to be actionable, or to be, more broadly specified to get that more holistic view of what's happening across a system or across an organization? Any thoughts on? I know we're not getting in too much into sort of the nuts and bolts of specifying measures, but thoughts about where new data streams may be that could help us in sort of a new era. Anytime we talk about measurement, there are potential for unintended consequences. And so for any of these things that we've laid out here, do you have any thoughts there? And then how do we think about the effectiveness of PSIs? So, we've had this conversation in quality measurement outside of PSIs, but if we're not seeing results, is it the measure's fault, or is it that we're not doing the things that we need to do to actually drive the improvement and paying more attention to the implementation science and the interventions that can drive improvement? So any reactions there, Annalise?
Yeah. So Wendy, great questions. I don't know that I have a yes or no or a clear, but I think about measure specificity. I think it's an important opportunity to really think about what are we trying to achieve with PSIs, right? As someone who works in a healthcare setting, it has been that actionability that has actually been really important to engaging our care teams in having these conversations. I think as we think about broad measures, right, it just gives you an inkling, right, that there's an area of concern that may not be as, right. So it's a broader data measure. It just gives you a sense of like, ooh, this is something that we need to look at. But I would say from a healthcare organization, I really feel like the actionability makes a difference. I did see one, and I have not closely followed the Q&A, but somebody did highlight the importance of input into these measures, just as you're getting today. But I do think clinical input, because there are some areas where there are certain things you can't change, right? Like coagulopathy, I believe, is in the Q&A. So just understanding really from a healthcare perspective, what can you impact? And I guess I would say, I actually like the idea of specific measures, because I think for accountability, right? Again, sepsis is an area that we know the overwhelming infection is a really high area of opportunity for us across the healthcare system. But because the definitions vary, I think having really clear definitions, exclusions matters. Unintended consequences, I guess I would say the one, really being clear on what it is that you're measuring, right? As we talked about a delay in diagnosis, and Libby highlighted this, right? If you think about a delay in diagnosis of a person who's asymptomatic, so that may be screening, right? So screening may not be something that a healthcare system can control. It could, maybe it's an access issue, but there are multiple factors that go into it. So I think as you think about actionability, it's actionability for whom, and then how do we work on that? And I think we have seen unintended consequences of, again, early recognition of sepsis is really important, but we also don't want to overuse antibiotics. So there are sometimes unintended consequences where you really want to focus on improving the safety. You don't want to just meet the measure. So I think that is important. And from the perspective of a healthcare organization and a healthcare provider, to me, the impact of PSIs are, did we make changes or identify areas of opportunity for improvement where we improved the outcomes for patients? So to me, that is the impact of PSIs.
Dr. Romano, any additional thoughts from you from the technical perspective?
Well, I'll just say that, as we think about measure concepts, this has come up in the Q&A a number of times. There's always a difficult trade-off between the specificity of measures and the sensitivity of measures, right? So we want measures to be able to identify as many of the events that are happening as possible, but we also don't want a lot of false positives. We want measures that don't lead us to waste a lot of effort on looking at individual cases. And this is a difficult challenge, right? Because sometimes as we try to make the measures more specific, sometimes they lose sensitivity and vice versa. So it's just an important concept that I think will be in all of our minds as we think about addressing these gaps.
Great, thank you. We had a couple of other comments that sort of got to, I think, how the PSIs fit into the broader ecosystem of measurement in safety. So, the PSIs, someone had a question about, one of the SREs, which the National Quality Forum is updating, the what gets reported to CDC through NHSN, and any thoughts on sort of what the opportunity might be there, what challenges maybe you all see in having the PSIs in one place, and then quality measures are in another space, and is it stable enough where everyone kind of has figured out the system and so it's working, or is there value to thinking about how to maybe do this in a more in a more coordinated fashion? Judy at the outset mentioned how we really wanted to try to use this opportunity as well to think about how the PSIs and the SREs could move more in concert. So just curious about how you see the ecosystem maybe being improved if possible.
Yeah, I think it's a great point, right? Because every organization, you can't focus on everything, right? So how do you ensure that you are really focusing on those areas where you can have the biggest impact on safe patient care, for example? So the concept of aligning these areas seems like a great discussion to have. I also think with newer technologies coming down the road, AI and there may also be ways that naturally that alignment occurs. Just may occur more. There may be ways to pull information out of an electronic health record, for example, or to bring together information from various data sources much more easily. So I think it's a great lens to have moving forward.
Patrick, any thoughts from you? I know we're winding down. We have about 7 minutes left in this session. I know.
Well,
go ahead.
Oh, sorry. I'll just note that as I think many of you are aware, CMS has led the development of electronic clinical quality measures. And so I think AHRQ welcomes input from people on this call and other stakeholders about whether AHRQ should also move in the direction of adopting additional data elements that may come from electronic health records, or including measures that could be implemented within EHR systems as electronic clinical quality measures. So that's definitely on the table, and we welcome input through MITRE's platform.
Great. Thank you both very much, and Libby, you as well, for this conversation. Thank you all to everyone who is participating to provide really great comments. I could not keep up with them, so I had to rely on my colleagues to send some our way that could be good fodder for discussion. I'm going to turn it over now back to Judy George for some closing comments.
This has been such an informative conversation. I'm just really pleased to see the level of engagement. I know there were many, many questions and comments that we did not get a chance to answer today, but I assure you we will be looking at all of those, and especially those who have concerns with any of the content that you heard during today's call. So I encourage you and urge you to take this opportunity to send those written comments to the MITRE team. They'll be accepting those through the end of June. And likewise, I know that there are many comments about the existing PSIs, additional suggestions, exclusions, and those can be sent to the other email address that is listed listed in the chat, and we'll drop that back in. There we go. Thank you, Kristen. I do want to just say a huge thank you to Dr. Annalise Slayer. Now, Annalise may have sounded like she's been working with all of this, all of our plans for months on end, but the reality is Annalise just agreed to speak with us just last week as our plans changed from who would be available for today's call. And we had a call just earlier today with Annalise to make sure she understood the logistics. So the point of having Annalise on here was really to just have an example of someone who is a user of PSIs be able to speak about their experience and offer their insights. And so I just so appreciate Annalise being the bold person she is, and coming on and being an advocate for what she believes is needed for her patients and her health system and her providers. I also want to thank Dr. Patrick Romano, who has been an integral part of the patient safety indicators, the quality indicators, and an AHRQ collaborator. So hats off to you, Patrick, always. I want to join me in thanking our MITRE team who has organized today's call and has been and continues to work on this effort. So thank you to Wendy, Kristen, Joe, and the entire team. This work was also done in partnership with our CMS colleagues who has taken a backseat to this call, and I just want to acknowledge them directly. That's Preeti Hans and Kim Rawlings from our CCSQ team over at CMS. So I just thank them very much, and my AHRQ colleagues itself, who you've heard of before, who have been on this call actively participating. And I want to acknowledge our quality indicators team that is staffed by the analytics side, by the Mathematica team, and our software and website side by Pantheon. And lastly, I want to thank you. Thank you all for making the time, offering your thoughts, considering how you want to engage with AHRQ in this effort, and your willingness to participate and share your input. We so appreciate it, and thank you for your ongoing partnership. And with that, Wendy, I turn it back to you.
I believe with that, we are concluded. So thank you for those remarks. Have a good day, everyone.